Number one, never underestimate this virus. I think that's what has gotten us into trouble over and over again, and thinking we knew something when we didn't fully know yet. And so I think this is where some people have been frustrated with the CDC, maybe not rolling back certain restrictions as quickly as they would like. But the fact is, I think they have been proceeding at a slow, measured way, because they really do want to make sure that we have a full grasp of the science.
Well, good evening, everybody, and welcome to your library. I'm David Leonard, president of the BPL and host of our Arc of History series. Tonight's conversation is the last, actually, in this sequence of our Arc of History Repairing America series. Our guest this evening, Dr. Celine Gounder, is an epidemiologist, a frequent public commentator on public health matters. She's also the host and producer of American Diagnosis, a podcast on health and social justice, and Epidemic, a podcast about the SARS-CoV-2 COVID-19 coronavirus epidemic, which she co-hosts with former U.S. Ebola czar Ron Klain, now the White House Chief of Staff. Dr. Gounder, it's so great to have you with us this evening. We have a lot to talk about, including some news of the day, but I'd like to give you the opportunity to tell us a little bit about your own personal story. How does one decide to be an epidemiologist? Is that something one suddenly wakes up one day and goes, that's what I want to be?
No, it was a bit of a journey, as you can imagine. I am the child of immigrants. My father was from a very rural village in Tamil Nadu in the south of India. My mother was or is from France. She grew up in Normandy in the aftermath of World War II. My grandfather worked in construction, and so, as you can imagine, there was a lot to do in Normandy right after World War II. They met here in the United States. So there's no question that their journey, and I would say in particular my father's journey, had a profound impact on me and what I wanted to do with my life. I didn't have a clear sense yet of what that would be when I went to college, and my father was a Asian tiger parent before the term really existed. Really had a sense that he wanted me to be the next Bill Gates, to study computer science or engineering and business and start a company. Yeah, exactly. And so it's kind of ironic, because you think Indian parents would be thrilled to have a child who goes on to medical school. But that was just not what he had envisioned. And yet I was good at math and science, but was really looking for a way that, at least in my mind, I would be leveraging those skills in public service, and very much had this idea of having been very fortunate in my life, in my trajectory, knowing that had I been born back in India, my life would have been entirely different. I would not have had the same opportunities. And so really wanted to find some way of giving back. And that's really what drove me towards working in global health, and eventually epidemiology and infectious diseases and the other work that I do.
And then in November, you were named to the Biden task force on the coronavirus epidemic.
Yes, that's right. And I should mention, so Ron Klain is no longer my co-host. He did have to step away because of his other responsibilities. As you can imagine, that's a handful. I've known Ron since the Ebola epidemic. We crossed paths back then. I was an Ebola aid worker in West Africa, in Guinea, for 2 months. But it was also doing a lot of media leading up to that, and after I came back, around Ebola. And I couldn't tell you exactly when Ron and I crossed paths, sometime in there. And as I was getting ready to head back from Guinea, he had reached out and said, hey, when you're back, when you're past your quarantine period, let's get together and just chat about your experience. I'd love to hear more about it. And we've just stayed in touch on and off over the years. He's really a wonderful mentor to many young people, such as myself, people like Craig Spencer, who himself had Ebola, was hospitalized at Bellevue. And we're very appreciative of that. But yeah, I was among the eventually 16 of us who served on the transition COVID advisory board. And it was really an honor. It was a lot of fun. And in fact, a subgroup of us continued to meet weekly just to work on some things together to keep each other apprised. And so it's really been a wonderful experience.
Well, I think we're expecting viewers to tonight's program to be quite across the spectrum in terms of their knowledge levels around the virus and where we are today. So I'd like to give you the opportunity to just set some baseline facts around, what is this virus? How does our immune system deal with it? And then a little bit about the vaccines. And I think you have some slides that your team has shared with us from the podcast that you do. So we can use those to illustrate maybe some of the basic facts to get everybody up to speed on what we're talking about.
Sure. So one of the members of my team is an illustrator, and her name is Una Tempest. In fact, she's a resident of Massachusetts. She's a townie, you could say, on Martha's Vineyard from a fishing family. So these are courtesy of her. So this slide shows you how the coronavirus is transmitted. And that's actually been a more controversial topic than you might think. There has been some debate as to whether the SARS-CoV-2 virus is transmitted through droplets or through aerosols. And there is an important distinction here. So droplets, if you imagine you're coughing, it's like that spray that you might cough out. Those are droplets where they're visible. And those drop to the ground within 6 feet of you, 6-foot radius. And so that's where that 6-foot rule comes from. Aerosols are much smaller. You may not be able to see them unless there's maybe some smoke in the air or something else that makes them more visible. And aerosols float through the air much longer distances. So this is important because it means that standing 6 feet away from somebody is not necessarily protective if you have aerosol spread. And what we have found is that probably the predominant mechanism of transmission is in fact aerosols. And so that means that the interventions that help the most, that are most preventive prior to vaccination of transmission would be masks and ventilation. Distance is important insofar as you are trying to reduce density of people. The more people you have in a room or in a space, the more likely one of those people is to be infected and more likely that they would be to infect other people.
Now, would Airborne be the next step? Or are we seeing that aerosol is another way of talking about a subset within Airborne?
Yeah, Airborne is synonymous. Okay. Those are the same. So other infections that are airborne would include measles, tuberculosis, smallpox. So this is not, an uncommon mechanism of spread. But this also was part of what led to the CDC changing its guidance for schools, for example, of saying, 3 feet apart is actually okay in schools, as long as you don't have too many students in one classroom, as long as they're masking, as long as you have decent ventilation. So this figure here on the slide is really just intended to show this is an airborne respiratory virus. When you're around other people who could be doing anything from coughing and sneezing to just talking, they are exhaling the virus into the air, and then the virus infects you when you inhale those infectious particles. And then this slide is to illustrate how the immune system attacks the coronavirus, and as we'll move through the slides, I'll explain, how the vaccines help us here. So what you have is really a race between your immune system, so that B cell and T cell you see in blue and purple, versus the coronavirus. And the virus is trying to multiply as quickly as it can, and your immune system is trying to respond and launch a counterattack to the virus as quickly as it can. Essentially, if the virus wins, so to speak, that race, that's when you get very sick. That's when you might die. When the immune system wins, that's when, and in other words, if it wins, it means that you are, your immune system is acting so fast as to control the virus. When that happens, you may have no symptoms, you may have very mild symptoms, but you get better. So this slide here shows essentially how mRNA vaccines work. So the mRNA vaccines include Pfizer and Moderna. And what you see there in yellow is the fatty lipid particle that carries the mRNA. It's this fatty coating, because mRNA is actually a very fragile molecule. And so you do need to protect it to be able to deliver it to your cells. And so what that squiggly mark you see there with the green and red, that's mRNA. And it's a code. It's kind of like a computer code. Here it's a code for the spike protein, which are those proteins on the surface of the virus. And so it's important to understand here, you're not being given live virus. You're not even being given dead virus. You're being given code for a tiny portion of the virus. So there's no way for you to get COVID from the vaccine. That's impossible. People hear mRNA and then they say, well, that sounds similar to DNA. Could that change my DNA? Your DNA is protected in the cell nucleus, which you also see in this figure here. And it's not possible, it's impossible for the mRNA to get inside the cell nucleus to where your DNA is protected. So the mRNA, it's impossible for the mRNA to change your DNA. Next slide. Then the other vaccine technology that we're using here in the US is, and this is a bit of a mouthful, non-replicating adenovirus vector vaccines. You could call that a viral vector vaccine for short. And the difference here with the mRNA vaccine, they both, in fact, deliver that same code for the spike protein. What's different is the delivery device. So with the mRNA vaccine, you're using that lipid fatty layer, those droplets of lipid to deliver the mRNA. In this case, you're using another virus that has been gutted of its genetic material. And that virus is adenovirus. It causes the common cold. But its DNA has been removed, and so it cannot replicate. And all you're left with is just that tiny bit of code for the spike protein that it's delivering to your cells so that your cells make spike protein and your immune system can learn to recognize that.
So
again, yep, sorry.
In some ways, I think both of these technologies, what they're really doing is, if you'll go with me as a layman, giving instruction and giving information to the immune system so that it knows how to build up an ability to resist the spikes around the coronavirus.
That's right. That's right. So this is how you sort of give your immune system a head start in that race. You teach it to recognize the virus before it actually encounters the virus, before it actually has to race the virus. Right. And so that way, when it does see the virus, it has a head start. It's already in the starting blocks of that race. And so that really gives you the advantage over the virus.
And as we're into the vaccine topic at this point, these are both newer technologies, but some of the code and language has been around for some time.
Yeah, I wouldn't say they're new technologies. They're old technologies that have been applied to COVID. So the mRNA vaccines have been in development since the 1990s. Scientists had been working on them more recently for SARS and MERS, which are related coronaviruses. And then the adenovirus vector vaccines have been in development since the 1970s. The Ebola vaccine, for example, is based on that technology. And we were really lucky, frankly, that we had those in development where they could easily be just modified a little bit, tailored a little bit to work for COVID. Because if we had had to start from scratch, we unlikely would have a vaccine for us today.
So does that really help explain why the development was able to happen, what looks to many of us as really quickly, but also why these results were able to get the emergency use authorizations as fast as they were.
Yeah, I mean, that's a part of the story, is that you essentially had these vaccines where you just had to change a part, that you just had to change the code that was being delivered. The delivery system was already there. And so that made a huge difference. Some of the other things that were done to expedite the development here, some of it was just putting a lot of money. If you work in the sciences, if you work as a researcher, you know a lot of your time is spent writing grant applications and waiting for that. It can take 2 years from the time you submit an application to NIH till you actually get funded. I mean, there's a lot of delay in that. So here they threw money at the problem and didn't worry so much about those normal processes. Normally, when you do your phase 1, phase 2, phase 3 clinical trials, so phase 1, you're really looking at safety, dosing, what dose you're going to be administering. Phase 2, you continue to look at safety, but you're starting to look at immune responses. Phase 3, again, we always look at safety, but in phase 3, you're looking at effectiveness, which means that if you encounter the virus in nature after vaccination, is the vaccine protective? And instead of doing phase 1, stop, then phase 2, stop, then phase 3, they did them overlapping, sort of in parallel. And that also really allowed us to do things more quickly. And then finally, one of the things that Operation Warp Speed did under the Trump administration was put a lot of money into manufacturing. So, you know, the pharmaceutical companies don't really want to manufacture a ton of vaccine before they have an approval, before they know it works. And Operation Warp Speed provided the funding to help them take that risk, to allow them to go ahead and start making a lot of the stuff before we knew for sure if we would even use it, because there's a risk in something that you might have to, you know, that might go to waste.
Would that mean there were other vaccine candidates that were also funded and produced that either didn't make it or haven't made it yet to this level of approval?
Yes, there are several other vaccines, in fact, many other vaccines that were being looked at. Several are more likely to come to fruition, but we're farther behind in development. But I do think we'll see at least 1 or 2 more vaccines likely being submitted to the FDA before too long here. I don't know whether they'll be really used in the US anytime soon. But it's still helpful to have that review, and you know, you never know with especially with the emergence of variants, some of these other vaccines may prove to be good alternatives.
Right, we may need more in the arsenal, either locally or globally, as time continues. So this is great. This is very convincing. It all appears to have happened really quickly, even though there's good reasons and good explanations for that. So can we talk about vaccine hesitancy and vaccine resistance? You know, I think we appear to have now a social problem as much as we do a scientific problem, which may not be real, and yet public health must take account of both the social and the scientific.
Yeah, that's right. I do think it's important to note that access does remain an issue. In particular, I think the one group I see that most is among Spanish speaking and other non-English speaking patients. Okay. We certainly are seeing the Kaiser Family Foundation, in fact, just released another report looking at Latinx communities in the US today. And there are very much concerns around immigration status. Are they eligible to get vaccinated? As well as, you know, the language barriers and getting the information about how and when and where and all of that. So I do think we still have work to do on that front. In the Northeast, where you and I are, we have the best access of the country, really, to vaccination. Other parts of the country, the Southeast in particular, some of the Rocky Mountain states do not have as good of access. So those are issues we do need to continue working on.
Do you see that as an availability problem or a communications problem, or a little bit of both?
Some of both. Some of the other barriers are people think they may still have to pay out of pocket, even though the vaccines are free. Some of it may be issues of having to take time off work, either to get the vaccine or being worried they may miss work due to side effects from the vaccine. having transportation to get vaccinated. So there's a number of access issues there. With respect to hesitancy, and I prefer to use the word vaccine confidence, because it's more of a spectrum, right? Are you confident? How confident are you? Not at all, or very, et cetera. There are a couple groups that stand out as having lower vaccine confidence. So communities of color, for sure, although we've made a lot of headway in that group, because in part, we really paid a lot of attention to that early on, did a lot of outreach. A lot of healthcare workers of color have been very actively working in their communities, educating them about their own experiences with COVID, their own experiences with the vaccine, and it's been effective. I think also just trying to make the vaccine as available and accessible in those communities has helped a lot. And then some of the other groups that are more, that have less confidence in the vaccines include conservative Americans, more rural Americans, and then younger people too. And those are for slightly different reasons. I think with conservative Americans, rural Americans, there's a lack of trust in government. With communities of color, it's lack of trust in the health system and having been discriminated against.
Right.
With younger people, it's more of this idea of, well, I'm not really at risk. Why do I need to take the risk of taking a vaccine when I'm not really at risk for COVID? And I think that group may have been even more exposed than others to some of the disinformation that's circulating online, unfortunately, on social media. And so that does seem to have had an impact as well.
So let's stay on the youth, and then I want to come back to the communities of color challenge in a second. Are you saying that young people in this instance are more susceptible to the disinformation or misinformation that's out there? Because I think that's what I heard you say, and that's frightening to me.
I don't know that they're more susceptible. I think they may be more exposed. And so, their dose, so to speak, it may be higher. I think they also are more likely to consume their news on social media. They're less likely to consume maybe mainstream television news, which is not always, accurate either. Unfortunately, they're less likely to consume their news reading the New York Times or, the Atlantic or the New Yorker or something like that.
And couple that with a sense of invincibility.
Yeah.
There we go.
Yeah, exactly. So, it's a bit of a challenge. And so we do need to work on that for sure.
And I think this is why we're starting, I think, to see celebrities, other trusted figures that are particularly relevant to particular communities, share their vaccination stories and begin to try and rally people around, like, this is not just a good thing objectively, but the person you like and trust has gone and taken the vaccine as well, so you should too.
Yeah, and it was interesting. Last night, in fact, I participated in a focus group. So the Republican pollster, Frank Luntz, has been conducting a series of these. So last night, it was me, Dr. Lena Wen, Dr. Ann Zink from Alaska, and 3 congresswomen who have healthcare backgrounds, and then a group of 20 or so young women. And it was really interesting to see what their perceptions were of the vaccines, of the disease. And I would say, there definitely were a lot of questions about long-term side effects. I was a bit surprised there were not more concerns about fertility, pregnancy, breastfeeding, especially in a group of young women. But there were a lot of concerns about long-term side effects. And in terms of incentives to get vaccinated, what resonated most with that group, frankly, it wasn't celebrities, it wasn't what their peers were doing, it wasn't I can throw away my mask, it was I can travel. Travel in that group is really important, being able to get away, go someplace else, explore the world. So, it's interesting, different groups respond to different things.
So in that context, is this where this concept of which is also controversial, a vaccine passport comes into play? And that would be an incentive then, if I took what you just said to its logical conclusion. But then I think, would we not worry about having another two tiers of dividing society into those who have it and those who don't?
Yeah, I prefer the term vaccine certificate or credential, because I think vaccine passport, and especially for certain members of society who are afraid of being tracked and having their personal data tracked, connotes the wrong things. It's not an identification we're talking about. We're talking about just, being able to verify your vaccination status or maybe your testing status. But there is not going to be a federal mandate that people be vaccinated. You're not going to see a federal vaccine credential system. Some states may go that route, and the states have the authority to do so. There's a Supreme Court case that goes back to 1905, also from Massachusetts, in fact, Jacobson versus Massachusetts, in which a man was, Mr. Jacobson, did not want to be vaccinated against smallpox, did not want his children vaccinated, and the state mandated that he be vaccinated because there were a lot of smallpox outbreaks at the time, including in Boston. So the states do have that authority. So some states will probably do that, in particular in healthcare settings and in schools. So for example, in New York State, as a healthcare worker, you are required to get a flu shot every flu season, or you can alternatively wear a mask the entirety of flu season. And I can tell you most people opt for the shot so that they don't have to wear a mask all the time. And I think so. Schools, healthcare settings, and then certain workplaces will likely require vaccination of their employees and perhaps also their clients. Here I'm thinking about the travel industry. I think airlines will find it simpler to require that that their employees, that passengers be vaccinated, than have to deal with policing mask wearing in a flight. Where you have some people who are vaccinated, some who are not.
So we've come up against this. If you're vaccinated, you do or don't have to wear a mask, and we just heard today from the CDC new guidelines. Would you mind just recapping what came out of CDC? Because I think you won't drop any of the nuances that are important to this new guidance if we hear it from you.
Yeah, no, of course. So what the CDC announced today is that if you have been vaccinated, you do not need to wear a mask indoors or outdoors. I think what's really important to understand is the CDC sets national guidance, which means that this is the minimum, this is the floor based on what the current situation is. But depending on where you live, local and state health departments may have higher requirements, more restrictive requirements. If you live in a place where there is more transmission in the community. In fact, I think your staff has a map. It's the one that's like red, yellow, orange, blue. Yes, this one. So if you look at this map, this is a map right now of levels of transmission of SARS-CoV-2 in the community. Places that are blue are counties where the level of transmission is very low. Yellow is a little bit higher than that. Orange is even higher, and red is places where we have a lot of community transmission. And so if you live in a place that's blue or maybe yellow, I think that CDC guidance completely makes sense. If you live in a place where the color is orange or red, you may, you and or the state or local health department may want to have more restrictive measures in place and still want to be masking, for example, when you're in mixed company, vaccinated, not vaccinated indoors. I think you would still want to be doing that in high transmission locations. I think what you're going to see in the next couple of weeks is that this map is rapidly going to change colors as more people get vaccinated. We've already seen a 30% reduction in cases just in the last 2 weeks related to vaccination. And I think as we inch up in our coverage, this map will increasingly turn yellow and blue.
Right, because I think if we think about Vermont, Massachusetts, and New York, for example, that we know are some of the highest, if not the highest, vaccination of adults over 16 so far. They're not all quite at the yellow or lowest levels of community transmission, which says we have a little bit to go yet in terms of seeing these two trends converge. So I think you're presenting therefore of the CDC changing guidance today seems very measured, that yeah, we're about to be ready to do this, but there may be some local conditions that in an ideal world suggest that we maintain some level of mask wearing, but know that we're on the way once we get below some sort of thresholds, we'd be able to be confident about reducing the mask wearing restrictions.
Yeah, I think that's right. And this other map that is on screen now is looking at the current vaccination coverage in adults, so over 18. And you do see that there are certain parts of the country where vaccination coverage in that the lighter, more green colors, so West Virginia, Georgia, parts of the Rocky Mountain states, again, where you do see lower vaccination coverage. And so those are places where your levels of community transmission will be slower to come down. So, the US is, we're a federal government, meaning that you have a lot of control at the state and local level, both in terms of policy and, I mean, as you can tell from these maps, in terms of disease transmission and vaccination rates. So you do need to have local adaptation to the guidance.
Yeah, I mean, I think, we're still probably too close to the current reality to have a true look back of changes in either whether it's COVID cases or vaccination levels over time. And I want to talk about this for the US first, and then maybe a little bit about the global situation. But different places seem to do really well, and then have second, third, or fourth waves of cases. And the predictability to that seems to have been very difficult to put numbers around. The most recent US example, I think, was the latest surge of cases in the Michigan area. For example, would you, as an epidemic, I mean, this is epidemiological analysis work. What is your take on this? Does this tell us something about us as a society? Does it tell us something about the virus? How do you put all that together?
Well, I think number one, never underestimate this virus. I think that's what has gotten us into trouble over and over again, and thinking we knew something when we didn't fully know yet. And so I think this is where some people have been frustrated with the CDC, maybe not rolling back certain restrictions as quickly as they would like. But the fact is, I think they have been proceeding at a very slow, measured way, because they really do want to make sure that we have a full grasp of the science. And with respect to Michigan was one of the first places that was hit by the UK variant, this B117 variant. It also hit Minnesota, Illinois, a couple other states in that Great Lakes region pretty hard. And that variant also caused a surge in the UK initially, where it initially emerged from. That's what prompted strict lockdowns in the UK around the winter holidays. It then proceeded to spread to Europe, where you saw many cities in Europe, for example, Paris, the hospitals, again, were overrun with cases. And then it came to the US. I think where we were very lucky is that we were farther along in our vaccination rollout by the time it hit us here in the United States. And so it did cause a localized surge in the upper Midwest. But fortunately, we saw that uptick and then it came back down again. And so I think we were relatively insulated from the worst of that.
And we have states like New York that really were in the vanguard of the the most tragic periods during this pandemic in the US, where vaccinations are now really, really high. We have other states where either because of population density or other reasons, containment was more effective, but now vaccination is not actually proceeding at the level that you'd want. So it seems very difficult to me to make a correlation that sticks between these phenomena at this point.
Yeah, I think another example of that is Florida. We really do not understand the story with Florida, because if you look at the behaviors with respect to masking, social distancing, I mean, the adherence to that was very poor. They have not had the best vaccination coverage. So we don't really entirely know how to explain that. Is there a seasonality, a climate aspect to this, a humidity aspect? We don't entirely know. Many of us right now are steeling ourselves for what may happen in the southern states this summer. Will we see another summer resurgence in that part of the country? We don't know.
Right. I think could this explain why other parts of the world in warmer climates, at least in the first year, don't seem to have seen quite the case numbers that one would have expected?
And I think India is a great example of that. Again, this goes back to this question of climate and humidity. Was there something protective about that? I mean, some people, and there are virologists and immunologists who are looking at this question, is it possible that the virus is less infectious perhaps in certain climates? And again, we don't have a straight answer to that yet.
And it seems to parallel one of the biggest questions early on, which was, I think, if I think back to what we were learning about in February, March of last year, was community spread really going to happen and take off? Was this going to be a real characteristic of the prevalence of this virus or not? And then trying to judge what did this mean about the transmission medium, where so much not known, and yet I also want to suggest that my understanding of public health, two of the fundamental data sources are you testing people and are you doing contact tracing? Which I think happened only in limited forms or didn't happen until much later. Is that a good read of the situation? And as you think about, it's probably too soon to really talk about many lessons learned, but those seem to be two of the lessons that we could learn.
Yeah, as somebody who worked in tuberculosis and HIV for many years, this is the fundamentals of TB control is contact tracing and testing. I mean, this is what we do. And in fact, every time there's been a big outbreak, whether it's Zika or Ebola or now COVID, it's the TB folks at the Department of Health in New York City anyway, who get pulled and reassigned to do this work. Yeah, I mean, this is how you figure out how is the virus or a pathogen transmitting, what are the places that are high risk. I think one of the, many of the questions we have, for example, about outdoor spread, how much have certain outdoor events contributed to spread? We don't have very good information on that. We have some sources of information, for example, that some of the political rallies last summer, in the aftermath, you could see an uptick in cases in those counties, but it's very hard to document the person-to-person spread because that contact tracing simply was not done.
Do you think we can learn from this experience? I mean, you certainly have experience with TB, Ebola, HIV, SARS. What should we have learned from these earlier viral occurrences that we did not in this case? And will we learn those lessons this time?
Well, we're having a lot of conversations about what is infrastructure right now. Is it roads and bridges? Is it childcare and other forms of caregiving? Is it public health? I would say public health is absolutely part of your infrastructure. And so that includes the people. That is a huge part of public health is the human resources. It's also things like your labs and your IT, your tech, your bioinformatics. And so, we had a lot of frustrations, for example, with systems to schedule appointments. Well, this has a lot to do with the fact that we haven't invested in IT and tech for public health really ever. I've seen some public health departments that still use DOS-based systems. So this goes back to the 80s. And so when you're dealing with such antiquated tech systems, it's very difficult to do some of the things that we have been wanting to do quickly. For example, just collecting data on demographics, race of who has received a vaccine and not. If you don't have the data systems to do that, it becomes very difficult to do things like ensure equity in your distribution. So I think investing in public health, recognizing that it is essential, critical infrastructure, that we pay for, the workforce, that we consider them professionals, that we scale up our laboratory capacity, and that it's not all centralized at the CDC, but you also have it at the state and local level. And that when we invest in our tech systems, I was very encouraged. The Biden administration announced today that it was going to be investing quite a lot, in fact, in hiring up and strengthening the public health workforce. So I think we're moving in the right direction.
At both the federal and the state levels?
Yeah, so that funding will be at the federal level. So for example, strengthening the CDC, where they are, I can tell you, massively understaffed right now, and the morale is extremely poor. As you can imagine, this past year has been really hard on that agency in particular. But also funding for the state and local health departments. There are some local health departments that will have just one public health nurse to care for that entire community. And as you can imagine, at a time like this, that person, they simply cannot do that job.
Right, there aren't enough hours in the day. There aren't enough people and technology. So just a reminder to our viewers, we'll in a few minutes start taking audience questions. So please, if there's something we haven't covered yet or something that we have covered that you want to ask about, please line up a question through the Q&A option in chat. The global situation, we seem luckier now at this moment. I mean, it seems, surreal to say that, having lost hundreds of thousands of people in the US. But right now, with vaccine availability, we seem luckier than other parts of the world right now.
Yeah, it's really interesting to compare ourselves to countries like Japan or South Korea that really did well early in the pandemic, because they understood masking and contact tracing and testing, and they did all of that stuff right. I think what we're seeing now, over a year later is, yeah, they experience fatigue as well. So there is some attrition in adherence to those measures, but they also do not manufacture vaccines in country. And so they are reliant, they're in line. And it's not that they don't have the money to buy vaccines. They're in line waiting for their turn to buy vaccines, and they're in line behind us and others. And so they have not been able to vaccinate their populations. And I think this really does speak to some issues at the global level with respect to how do you make sure everyone has equitable access, and our system right now certainly does not achieve that.
And I don't want to be crass or oversimplify this, but this feels like it's our capitalistic approach to this problem that cornered part of the market around vaccine production that has enabled us to move ahead at this point in time. And I think some of the commentary on this talks about vaccine equity globally. And there are efforts, I understand, to try and redress this imbalance. Are those things that you can tell us a little bit about?
Yeah, so you may have heard that the Biden administration recently came out in favor of what we call the Trips Waiver. So this is essentially an intellectual property waiver that would allow other countries to produce vaccine, whether it's the Moderna vaccine or one of the other vaccines. But the challenge here is that you would still need to be able to reverse engineer the vaccine. You're not being given the recipe. You're not being told how to make it. You're just being given the right to make it. And so this is a bit different from other pharmaceuticals where, for example, generic drugs like a pill, that's a lot easier to reverse engineer in the lab. A vaccine, which is a biological product, not a chemical product, is much more difficult to reverse engineer. So you need really to scale up manufacturing to give people the right to manufacture, and then instructions on how to manufacture. They need to have access to the raw materials to manufacture. So it's a much more complicated process. And there are some efforts underway. The Biden administration is assisting or supporting a company called Biological E in India to manufacture the Johnson & Johnson vaccine there, for example. But we still have not seen this kind of support globally at the scale you would need to get everyone vaccinated as quickly as they really should have access.
Yeah, you mentioned India, which is going through and which is close to your own family. This is, absolutely the worst of the tragedy that they're experiencing right now. And this is a country that's also known for its production of medical treatments and vaccines in particular. Can you have insights into squaring that particular circle? Will this release of patents or relaxation of patents allow them to accelerate their responsiveness, at least on vaccines, if not on the current experience?
Yeah, so India is the biggest manufacturer of vaccines worldwide, the biggest. But you also can't make vaccines without raw materials. And part of what happened when the Biden administration invoked the Defense Production Act early on to scale up our production of vaccines, that meant also banning export of certain raw materials. So those raw materials stayed here, could not go to countries like India for them to use. So, they have the capacity, but they don't have the materials they need to produce. So that's been part of the challenge in India.
And what's an example of a raw material in this context? So, I think we know when we build buildings, we have steel and wood and so on, but what's the raw material that we're talking about in this context?
One good example, if you remember that mRNA vaccine I was showing on the slides, that lipid envelope that you use to deliver the vaccine, that is one of those raw materials that has been, we've really had to work on over the last several months to scale up supply. And that is one of the raw materials that is not being shared with other countries right now.
Moving to Europe, which is closer to my own family background in some ways, there's a very mixed set of stories here. Also, we have the UK, where the UK variant, as it became known, certainly became much more prevalent, much more dangerous. But now we also have examples of their vaccine compliance accelerating compared with the rest of Europe. Yet in Germany, we are having another wave, or we're just coming through another wave, where examples we have of countries like France, Spain, Italy, Germany that did lockdown real early on. And yet, so is this exactly the same phenomena that we were talking about 10 minutes ago in the US in terms of the difference between states, because it's one landmass?
Yeah, I do think it's similar. You could say the EU is a bit like the United States, where each separate state in the EU, each country kind of has its own local approach to things. I think there's an analogy to be made there. And so you are going to have some regional differences. I think the EU had some bad luck in terms of which vaccines it signed up to purchase. Also in terms of whether the companies made good on the production on the timelines they'd originally promised. And so that certainly has challenged their vaccine rollout. I think the UK has been pretty lucky in that respect, that despite having the variant emerge, their vaccine supply has been reasonably consistent and good.
Right. So let's just talk about what next? I think this seems to be about continuing containment and improving vaccination accessibility and equitable delivery. Is that right? Is there more? What's the right mix of what next?
So I think what next in the US is certainly trying to improve access, trying to get to people who might be less confident. I think that you're seeing a shift, a pivot from a mass approach, whether that was mass vaccination sites, public service announcements, mass information, to having to deliver on a more local basis. So through primary care providers' offices, through community health centers, through mobile and pop-up clinics. And then with respect to communication, also going hyper-local, trying to enlist primary care doctors, pharmacists, and other trusted people in communities to do that messaging. It's a lot more one-on-one conversation than a slick ad on television that we're needing right now. So I think that is part of what next. I think we are, as you see the local epidemiology evolve, that whether it's through guidance from health departments or just through people's own behavior, I think we will, over the course of the summer, start to shed our masks and eventually do that indoors as well. And then I think the other thing in terms of what next is the variants. So really keeping close tabs on these mutant viruses that are emerging. And this is where it's really important that we pay attention to what's happening in places like India, because these viruses, these mutants emerge where you have widespread transmission. And so we do need to keep tabs on that. Right now, all of the vaccines we have here in the United States are effective against the variants. But that may change as the virus mutates and evolves more. And so we want to stay a step ahead, not be reactive should that happen.
Yeah, I think I was listening and I'm sorry, language clarification. Can we use the terms variant and mutant interchangeably, or is mutants a subset of a variant, technically speaking?
Well, I pair them together because I want to make sure people understand that when we're talking about a variant, it means it's a mutated form of a prior, version, strain of the virus. So you could say it's sort of redundant, but I do that intentionally to be as clear as possible.
Great. And listening to the latest update from India, where new variants have emerged, the confidence level around existing vaccines still appears to be pretty high.
That's right. So we have looked at the currently available vaccines. They do still seem to be effective against the Indian variant, which is the B.1.617 variant. You may see some breakthrough infections with mild symptoms, but in terms of the most critical outcomes, which is severe disease, hospitalization, and death, the vaccines are effective against really all the variants for now.
It seems like part of the goal is to make this feel a little bit like it's like the flu vaccine. I mean, we wanted to shy away from comparisons between COVID and the flu real early on, but in terms of just going to your local doctor, we want to get to the place where it's as simple as just getting any other type of vaccine. There's a sense of the need for booster shots, possibly. And to me, this seems to have, if this is right, two reasons to do that. One is to tweak the vaccine to combat new variants that may emerge, but equally to just maintain the level of resistance and strength of the immune system. Do you have a sense of whether that's right and what sort of time frame we're talking about for booster shots?
Yeah, I think that's right. So the idea of a booster shot is, one, you're boosting the immune system. We don't know how long the immune response to the vaccination will last. Right. With some vaccinations, that immunity lasts forever, essentially lifelong. For other vaccines, for example, tetanus, you get every 10 years. It depends on the vaccine. And so that's something that remains to be seen. In terms of updating it for new emerging variants, just the way we do, because the flu shot, or excuse me, the flu influenza mutates, I do think it's important to understand that they mutate in very different ways. Influenza mutates much more significantly, and this has to do with the way its genetic material is encoded. And so that's part of the reason why we do need to get yearly flu shots, because it mutates so significantly. With coronavirus, we think that in the first couple of years following spillover from animals into humans, yes, you're going to have a fair amount of mutation as the virus adapts to a new host. But we don't think that's going to be forever. We think that's going to plateau. So I can't tell you, exactly, but I think we're probably looking at a couple booster shots, perhaps in the first couple years of this, but that will not be a lifelong situation.
Interesting. And is there a difference between the immunity, based upon what we know so far, right? The immunity you get from having had COVID, because that helps your immune system will eventually kick in and deal with that, versus the immunity that we're getting from a vaccine?
Yeah, this is a really important point. They are different. The immunity you get from a natural infection is much less reliable. It's a little all over the place. Some people will have a strong immune response to natural infection, some and many do not. So it can be a weaker immune response, and it may not be as durable. So that's one important point. Secondly, and this is where the variants are really important. Many people who are infected with an earlier form of the virus will not be immune to the variants. And so Brazil, I think, is a very good example of this. The city of Manaus, which is in the Amazon, had a terrible resurgence from the P1 variant, which is common in Brazil. And many of those people, the estimates are 75% of people living in Manaus were infected in the first round. And yet they were reinfected by P1. And I don't, many of you probably saw in the news, the horrible photos of hospitals overrun, running out of oxygen, having to build vertical graves because so many people were dying. So that's not something to be underestimated. Just because you had COVID before, you really still should be vaccinated so that you have a stronger, more durable immune response, including versus the variants.
And I think you've also, early on said that we should not underestimate this virus. And I think I saw Tony Fauci interviewed on CNN recently, where he was describing a technique of personifying the virus to, almost give it either evil or smart characteristics because of the way it can, infect us as individuals, be transmitted in society, and these variants and mutations that we're talking about continue to make it very complicated to deal with.
No, I think that's right. I mean, I think this virus has been so surprising in so many ways. It is stealthy, it is a chameleon, the number of ways in which it can cause disease. I mean, it really is, from an intellectual perspective, very interesting, but also really scary because of how many different ways it can harm us.
Which I think is why it's also very disheartening to see people try to dismiss it in the simplest terms possible. Particularly for those of us who have lost family members or dealt with tragedy or just seen the incredible damage it has done to our society, and whether that's in economic terms or personal terms.
Yeah, no, I 100% agree with that.
Let's take some of these questions I keep promising to pick up, although we've covered a few of the topics in our own conversation. And obviously, if any of these pertain to an individual's own health circumstances, we'd want that to refer them to their local physician. So Jerry asks, if the variants create implications for the continued effectiveness of the vaccines, so do we have to track every single vaccine's effectiveness with every single variant? How do you as experts deal with that?
Yeah, so what the CDC is doing is they take a random sample of the strains of the virus that has been isolated from people who test positive, and they sequence them and they look to see what mutations are there, and that helps them identify what might be a variant based on the genetic sequence. And then they have to further characterize them and test them. And part of what that testing includes is taking the antibodies from somebody who has been vaccinated, taking that serum and testing it against the newly identified variants. And so that's part of the routine surveillance that's being done. I will say that was not being done at scale up until recently. That was something that was dramatically scaled up at the CDC starting really late January. But we are doing that really at scale now.
And we've talked about the term effectiveness here, and I'd like you to distinguish between effectiveness of the virus and efficaciousness. So there's when is the individual's vaccination most effective versus the vaccine being effective against a particular variant? Because I think that can be confusing to people.
Yeah, so when we talk about effectiveness, what we mean is if you are vaccinated, as compared to somebody who is not, a group of people who are not, and then you're all exposed to the virus, how many of you, what percentage of you in each group gets infected? The group that was vaccinated, the group that was not vaccinated, and how do those risks compare? So when we say 95% effectiveness, it means that if you have been vaccinated, you're 95% less likely to be infected as the person who is not vaccinated. So one, it's important to say that's not zero. And so that really depends on how much the virus is circulating in the community. Here I'm just gonna throw out some numbers, some round numbers to make it easy. Say you have a baseline risk of 1 million and you have a 95% risk reduction, you get down to 50,000. If you start with a baseline risk of 100, you get down to a baseline risk, a 95% reduction of 5. So 50,000 and 5 are not the same, which is why there still has been, there are still some people, myself included, if I am in a place where there are high levels of community transmission, I may still want to wear a mask indoors because there's still that 5% chance against a high level of transmission in the community.
Which is really why not only do I want to maximally protect myself, but I want to try and make sure everybody around me is doing the same thing. And that's just the socially responsible thing to do.
Yeah, and I think another thing that is really important for people to understand is vaccines work best at a population level because what happens is, as I mentioned, you have that relative risk reduction to yourself, but then the more people who are vaccinated, that baseline risk also goes down. So you get down from that, million baseline risk to 100, and then you yourself have a 95% reduction in risk. And so that gets you down to a much even lower risk. So it really, yes, it's great to get yourself vaccinated, but you really do want to encourage all of the people around you to do so as well, for their benefit as well as for yours.
Which would also mean lower rates of transmission, so fewer cases, but also that's fewer opportunities for more variants to develop, right?
Yes, and that's a really important point. The more the virus replicates, even if it doesn't cause, that person's severe disease, the more it replicates, the more opportunities it has to mutate, because every time it replicates, it has the opportunity to mutate. And the more likely you are to see mutations that could be the next variant.
The next question we have is if there are any chronic diseases that we're aware of that would preclude someone from getting the vaccine, or I would suggest maybe they should, or waiting if not precluding.
I would say not precluding. There are certain groups where they may not have as strong an immune response to the vaccine. So for example, patients who've had an organ transplant who are taking immunosuppressive drugs, or for whatever reason, have an immunodeficiency, immunosuppression where their immune system is weaker. These are people in whom I would still vaccinate. It's just you may not get as good of a response of protection. And so, part of how you protect that person, again, is you also want everybody around them to be vaccinated as well.
And in congregate living situations, this is yet another reason to preserve perhaps some mask wearing, some social distancing, and so forth.
No, I think that's right. So I think college campuses, one, I think many colleges, universities are already saying, look, to come back to campus, we want you to get vaccinated. And I think in places where that doesn't happen, there may be some requirements that, at least in certain indoor places where you have mixed company of vaccinated and unvaccinated, that there are some masking requirements.
And it also, I think, means that for someone who does have a respiratory condition that may make mask wearing more difficult, the very fact that the rest of us are following these protocols allows them to have confidence in having a close to normal life as well.
That's right. That's right.
Lynn asks, is someone fully vaccinated able to transmit the vaccine? It says transmit the vaccine, but I'm assuming the question might mean transmit the virus.
Well, so that's an interesting question. Both are, actually, because I have been asked both. So to be very clear, you cannot shed vaccine or virus if you have been vaccinated, because there is no live virus or even dead virus in the vaccines. So there's no shedding of infectious material that others could be infected by. So that's one. Two, if you have been vaccinated, could you get infected and transmit onward to others? Yes, it seems to be, based on the data we've collected so far, very low risk, in particular with the Pfizer and Moderna vaccines, more so than the J&J vaccine. It's not zero, but if you've been vaccinated, your probability of getting infected and passing that on to others is definitely reduced.
And would be the remaining instance of asymptomatic transmission more than likely?
More than likely, yes.
Right. Okay. So I want to go back to, we touched on this in our discussion. I have a few questions from the registrations that people submitted when they were signing up for tonight's program. What can we learn from the impact of COVID-19, and how do we prevent ourselves from having this happen again? The we is not defined. So it could be any of us. It could be the human species, or it could be us in the U.S. or in other countries.
Well, we already spoke about the need for building public health infrastructure. So I think that's certainly part of the answer here. Another part of the answer is you should never politicize a pandemic. And this is not the first time I've seen this happen. For me, it was deja vu all over again. From Ebola, in 2014, we had our midterm elections. This was definitely a wedge issue. Then the conversation was around, do we close our borders? Do we quarantine people? And then at the same time, some of the countries in West Africa were going through their own presidential elections. So in Guinea, where I was, for example, this was definitely politicized. You had people of the president's party wearing yellow t-shirts with his face on them, going house to house, doing Ebola education, really doing campaigning under the guise of health education and using those funds for that. And people were really unhappy about that. Imagine somebody with, whether it was a Biden, t-shirt, or somebody with a MAGA hat coming to your door and talking to you about COVID. You may not have responded so well to that. And so, what happens in those situations is that people will assume that there's an ulterior motive, even if it's the same political party as yours. They will believe that there's an ulterior motive behind the message and will not buy in. So I think that's another key lesson here. And then the other one I would speak about, sort of at the world level, is we need to have a plan for how to address this effectively, promptly, equitably worldwide. And we really still do not have mechanisms to do that, because we are going to have more pandemics. We know that, and we still don't have a system in place to deal with that.
Just to follow up on that, could this have been worse?
It certainly could have been worse. It's hard to imagine in some respects. had we not implemented some of the mitigation measures and we just let things go, I mean, and you could say in Brazil, in some ways, that's what has happened. Yeah, it could have been worse. It could have been worse.
I mean, a more fully airborne version of a virus like this may have been more difficult to contain.
Well, if we had started off with the B117 UK variant, there's no question we would have had many, many more deaths. That virus is about 1.7 times as infectious, which may not sound like a lot, but
it's an exponential infection rate, right? It's not just
exactly
right.
Exactly. So that would have translated to many, many more deaths.
And there's a dimension to this politicization question that seems to demonize a group of others. We've seen this in particular during this pandemic with the rise in incidents of hate crimes against Asian Americans in particular, or people of Asian descent. And this is that part. Do you see that for these other politicizations? We're essentially othering people based upon how we perceive them to be different than ourselves.
Well, it's a way of saying this is not going to happen to me, right? It's going to happen to them. It's not going to happen to me. Yeah. And so if I just keep them away from me, I will be okay. And so this has happened over and over again. You can think back to HIV with, the idea that Haitians were the ones carrying HIV. You can think back to, even farther back in time, the plague outbreak at the turn of the century in San Francisco in the early 1900s, where that was blamed on Asians, on Chinese people. So this is something that happens over and over and over again in history.
So this is kind of another interesting epidemiological question. In areas where vaccination rates are relatively low, will a higher percentage of unvaccinated people eventually get COVID? It probably depends on the transmission rates, right?
Yeah, it depends on the transmission rates, depends on population density. Is this a place where it's cold and people are maybe indoors a lot? Is it a place that's temperate where people are outdoors much more of the year? It really depends on a lot of those conditions.
This last question from the registration talks about people who might have died because of COVID-19 restrictions or lockdowns. It's kind of like the unintended consequences, if you will. I think certainly, if I can put my own spin on this question, we saw all of our healthcare system being repurposed and positioned to deal with COVID-19, which meant that other either serious perhaps or moderately serious illnesses and conditions weren't able to be addressed at the same rate or at the same time as they were. Are we doing analysis of that, or is there a way to just gauge that?
Yeah, there are a number of people who are studying this. And there's no question, for example, if you had a stroke or you had a heart attack at the height of COVID, here in New York City, you were just not going to get the same level of care because we were not going to be able to respond as quickly in those cases. When your hospital is completely full, when your emergency room is completely full with these patients, it's right. Very difficult. So that certainly, I think some of the other secondary deaths from that period, we definitely have seen an increase in opioid and other drug overdoses. So people were not able to access care for those conditions in the same way, maybe not able to access methadone and other opioid substitution therapies during that period. So, and people are, when they're isolated, they're, if they overdose, there's less likely to be somebody else there to call 911 to get them help. And another thing, and this has been something that's been talked about a lot, is the mental health consequences of social distancing and those mitigation measures. And some of the mental health researchers I've spoken, including to folks who are in Boston, where you are, is that the biggest predictor of having significant mental health issues was having problems with money and housing and those basic needs. And so, that may not be intuitive to everybody, but providing, things like the paycheck protection program, or those checks to households, that made a huge difference actually, because that allowed people to stay in their apartments, to be able to put food on the table, even if they might have lost a job. And that has tremendous mental health consequences. And so was, protective, at least to some degree, for some folks.
It may have meant survival in many cases. And there's the Maslow hierarchy of needs. If we're not meeting our basic fundamental needs, then we don't have a shot at meeting our mental health and quality of life needs either. So
right.
And that's let alone what I'm now referring to as the deferred trauma and grief experience of this last 18 months, which will have its own, will show up in its own way, as all grief and trauma does in the months ahead, presumably. So there's a second wave of public health reality that we will be dealing with as a society.
Yeah, I mean, I think for healthcare workers like me, who are re-engaging with our friends and families, I think it is hard. I think some of us have been traumatized by the way we've seen others behave during this. And, we've had our nose to the grindstone trying to care for patients and do all the rest of the things we do. And I will definitely say it's not that I'm going to go out and criticize certain people, but I may not seek them out the way I might have pre-pandemic. And my closest network of friends has certainly shifted over this period. And there's certainly a sense of loss that goes with that.
Right. And I think, we were reading that for many companies, oh yeah, it's fine, we'll just stay remote. It seems to be more productive. For some people, there's a dimension of greater quality of life. I'm not so bullish on that model staying in place. I think our need for in-person connection and experiences is vital. And certainly from the point of view of a public library, we're expecting people to really want to come back to our spaces once we're able to reopen them again. And I think this is a phenomenon we'll see in other parts of our society, that people will want to gather. And they may be cautious at first. It's not going to be, I think, for most people, rush out and have 100-person parties or whatever. But I think we'll want to be around others again. This in-person need for connection is really, really important.
I would agree with that. And I, as somebody who works in a hospital, we cannot remote work, when we're doing patient care. And so I have been around.
Telemedicine has its limits, right?
Yeah, exactly. You can't intubate a patient by, telemedicine. So, I've been fortunate in a sense that I have had that ongoing in-person camaraderie, contact. Yes, we're all masked and so on, but we're around each other. And I think there is something that has been very nice during all of this to be able to share, frankly, what has been a traumatic year with others who really understand it and have lived through that with you.
Well, we're coming up on time, so I would just want to give you an opportunity before we close out to offer us any final words on what is the public health expert and person who has lived through this with the rest of us. What words of wisdom would you like to end on?
Well, first, I would just like to thank you for joining us here tonight for this conversation and listening in, and for your questions. I want to recognize this year has been a horrible year. for all of us, and to give yourself the grace to give your friends and family the grace. I don't think it's helpful to go out and criticize people. It has been a very difficult year for all of us, and to give people a little bit of space. Some people may take longer, for example, to stop wearing masks. Some people may have already done so, for months. And I think we need to move away from attacking one another's behavior, and really just try to be more supportive as we emerge from this, and try to build back better, to really recognize what have been some of the weaknesses, liabilities in our systems. How can we do a better job next time? And in medicine, we talk about, more of a systems thinking approach, as opposed to, blaming certain people. And I think that's the way to think about this. This is a collective problem. How can we all do better together?
Well, Dr. Gounder, thank you so much for sharing your views, your experience, your knowledge, and doing so from a place of real empathy tonight. Thank you very much for joining us. Once again, thank you all for joining us tonight. Once again, Dr. Gounder, thank you. To all our viewers, whether you're watching us live or later in the recording, please be well, be safe, and see you next time.